untapped potential. I strongly believe it is untapped potential. However, without regulation, without the investment, sadly, some of them will remain as dangerous concoctions and perhaps cause more harm than they do provide the benefit. So hopefully that has given you an insight into the opportunities herbal medicine produces for Africa, but the requirements for us to really have a joined up approach in resourcing this area so that we can tap the untapped potential and address some of the challenges that we are facing in Africa. Thank you very much.
I'm delighted to say Professor Kanonga joins us now. Can I call you Edward?
Yes, that's fine. Thank you.
Great to see you. And thank you for sharing that information, particularly the story of your grandpa. We were all sitting here fascinated. He sounds an incredible man. And to live to over 100 years old with the things that you've talked about, he's a role model, an advocate for traditional herbal methods, isn't he?
Yeah, absolutely. I mean, he was a pillar of the family, and we owe a lot to him. And it was not until I started working in the health sector and public health and doing lifestyle medicine that I actually reflected on his life, and it had such a profound impact in terms of understanding, without the benefits that we now all have of science, how he used what was available to him. And how that led to improved health outcomes. And he was not just unique. I'm sure if we had the time, we asked people, they would be talking about their grandpas as well. So, yeah.
I think certainly in my childhood, it was always passed down through families, these methods, and you never really questioned why. I remember if you got stung by a stinging nettle, my mum would say, wet a dot leaf and press it on the sting. And I mean, I wonder who ever discovered that. But these things, I don't know, are they fading out, these traditions that are being passed down, do you think, maybe in Africa or beyond?
Yeah, I think one of the biggest challenges for us in Africa is that a lot of our history was oral tradition and passed on through storytelling and never really properly documented. So I'm afraid that there is a lot that, had it been documented, we would have been utilizing. I mean, in my village, it was very rare to hear someone going to the clinic because you had to travel and people had to make do. And some of these things did work and we saw improved outcomes. But when the person dies, sadly, they go away with all that knowledge. I mean, I wish if I could reverse time, and still have the insight that I now have, that maybe I would have been visiting my granddad every other weekend and scribbling down lots and lots of notes. So sadly, the tradition gets passed on from person to person, never really documented. And when the person goes, they go away with all that knowledge.
And I think you've hit the nail on the head there. We're hearing a lot in the public domain about clinical trials, about data, about case studies. And of course, with those traditional villages that you spoke about, they were the original clinical trials. The proof was there. But as you say, without science backing it up, which we all seem to rely on rather than storytelling, and those stories become mythical a little bit, we probably missed out. How do we re-energize that, those case studies from tradition and get them back in the public domain? What do we do?
So I think there's an urgent need because we still have, like my parents' generation, who will have had some of that information passed on to them. We need to document that. We need to really invest in research and engagement with those communities. And we need to make sure that we do these things properly. I mean, we have seen, sadly, with the COVID-19 pandemic, an over-reliance on some of these untried and untested herbal medicines And sadly, for some people, it has ended up with poor outcomes. So we really need to respect that herbal medicines do work, but we need to make sure that we subject them to the same level of rigor that even your paracetamol or Brufen goes through before it can be utilized safely. Otherwise, we end up harming people with the best intentions. So I think it's a meeting of how do we capture what we already have, but at the same time subjecting it to the same level of rigor so that we can satisfy ourselves that these things are safe, they're effective, and when they should be utilized. So it's not a blanket, use this for whatever ill you have. We need to make sure that we understand the indications and the contraindications of some of these treatments.
There's a little bit of confusion. You mentioned the COVID-19 pandemic there, which is obviously worldwide news and continues to be so. Is that this idea that the life cycle of a drug goes from, being discovered through to clinical trials, different stages of those trials, which can take 12 years. And here we are, barely a year after the pandemic, with a vaccine. And people are very suspicious, aren't they, of how have we gone from 12 years to 9 months? I did read somewhere that the professors at Oxford University had already begun the work. They just needed the acceleration of funding and the political will. What would you say to that?
Oh, you're absolutely right. I think the reason why drug development, whether it's a vaccine or a new cancer treatment or a treatment for some of the neglected tropical diseases, the reason why it takes forever is exactly what you've highlighted. There is no political will. There is no financial interest in those who can fund research. And there is, the governments really have got their interests elsewhere. I think what COVID-19 did was it brought all of those things together and demonstrated to us that where the political will is there, where pharmaceutical companies are willing to invest, where the governments are willing to support that investment and underwrite, we can do these things in breaknecking speed. So I think one of the challenges that we now have is if conditions and if some of these problems affect a part of the world that is separate from the Western world, then it is not in their interest to be providing the funding for research. And that's where, from my point of view, Africa, and that's the biggest lesson for me from this conference, the takeaway message is we can't be relying on others doing what we need to do. We can't be relying on philanthropic organizations. We can't be relying on international aid to solve Africa's problems. We are seeing that with the vaccines at the moment. Here in the United Kingdom, we are vaccinating 20-year-olds. And yet in some parts of Africa, even healthcare workers and the most vulnerable people still haven't had access to those vaccines. So I think for me, the solution lies in Africa. We've got the resources, we've got the hubs, we've now got an increasing body of people who have been trained, who can do this. Let's pull that together and start developing local solutions for local problems. And let the West come and join in and support our efforts rather than the West taking over the agenda and we sit in the passenger seat watching them drive at a speed that is convenient to them.
Yeah, I would agree. I mean, I'm sitting in the UK also, but I would absolutely agree. And that's the whole point of Africa Health Week, which is running over these 3 days, is to highlight all of the good work and the potential in Africa. And as you say, let's move that on. My grandparents, like yours, used to say prevention is better than cure. And of course, hospitals and doctors and medicine in general is set up to cure. But I'm sure a lot of these herbal solutions are proven to prevent illness in the first place. I mean, even as basic as my mum used to say, eat your vegetables, eat more fruit, drink more water, get some exercise. And herbs and medicinal solutions like that have a role to play.
Absolutely. I mean, the whole preventative medicine agenda is built on basic pillars of good lifestyles, good nutrition, physical activity. My granddad never went to a gym. My granddad never went to Weight Watchers or any of these Slimming World products, but he was not obese. He tilled the land. He would walk to his neighbors. My granddad never had depression or any of these because he was a family man and he was interacting. And there were other things that he would take as part of that preventative agenda. And we've got that in abundance. I mean, in the interest of time, I won't bore you with lots of compelling evidence that demonstrates that if you eat like your grandpa, if you had your lifestyle like your grandpa, certainly my grandpa, then that will lead to improved health outcomes and prevent some of these diseases. But sadly, we have kind of moved on to these westernized approaches, and sadly, those are the things that are killing us.
Yeah, I mean, I'm an advocate. I'm a fan. I'm feeling maybe that you should write a book based on your granddad's story and maybe other stories from that generation and bring that back to life, because I do think that future generations will be looking for alternatives to what, as we have seen, especially in the West, as the sort of pharmaceutical options, and there has to be another option. Fascinating, absolutely fascinating. And you're the first person in Africa Health Week to highlight the role of tradition and herbs. And I want to thank you for sharing that story, and thanks for joining us, Professor.
Oh, that's great. Thanks for having me. I mean, there are so many imperatives on why we should utilize these approaches. List of which is we cannot afford the rising and escalating cost of healthcare. We just can't afford, even in the United Kingdom or the US, we just can't afford that. We can't afford people dying from preventable causes, and we can't afford not utilizing resources that are at our doorsteps. So we really need to galvanize efforts to really make sure that these are safe, that they are effective, and they are utilized in a responsible way. I believe there is enough space there for herbal medicines, but they just need to be done properly.
Brilliant. And perfect note to end. Thank you for joining us, Edward. Fascinating story there. That's Professor Edward Kanonga, who you can watch that presentation again on the Future Health YouTube channel if you want to go through those slides, make a point, and of course, make a comment in the chat, stay on the network, and continue the conversation about that role, potential role of traditional herbal medicines and treatments. Okay, let's move on. Our next presentation is entitled Babylon, Making Quality Healthcare Accessible and Affordable for All. It's presented by two people. One, Claire Morris, is the Director of Social Impact at Babylon Health. She's joined also by Dr. Shivon Bayomakama. She's the Managing Director at Babel Health Rwanda, and their presentation is coming up next.
Hi, good afternoon and good morning. We're really happy to have the opportunity to speak at the Africa Health Week and to talk about our work, Babylon Health's work, both globally and most specifically in Rwanda. So I'm Claire Morris and I'm the Director of Social Impact at Babylon Health, and I'm joined by Dr. Shivon Bayomakama, who is our Managing Director of Babel in Rwanda. We'd like to talk to you today about our global work, which is really around our mission and vision to make quality healthcare accessible and affordable for all. We set off with this vision really with a view of considering the real challenges globally around healthcare, which of course will be very, very, everybody who is part of this week working in healthcare in Africa will be very aware of the challenges of lack of resources in healthcare, the affordability of healthcare, and it's something that Babylon is determined to try and help solve. And we're doing this by thinking both about the accessibility and how people could use their mobile phones to access as much of their healthcare as possible, as well as how we use technology, particularly AI technology, to make everything that we do more affordable, and how we really ensure that we strive to have the highest possible quality in everything that we do. So as a company, we actually were founded in the UK, in London, which is where I am now. And we've gone through an extraordinary journey over the last few years of growing, both in terms of, most importantly, the number of patients that we're able to serve, but the number of countries in which we're working and the number of partners that we have as an organization. So this is just a snapshot of some of the achievements and coverage that we have. Very importantly, thinking about our patients. Both we are now covering 20 million patients worldwide, and is critical to us what our patients feel about the service and products that we provide them. So we are always looking at the rating, and we're very proud to have 90% of our patients rating us 4 or 5 stars, which is critical to us as an organization. We now have over 2,000 team members across different geographies. And I will now talk a little bit more about the different geographies and partners with whom we're working to really make healthcare affordable and accessible for all. So we actually kicked off our work in the UK, started in fact with virtual consultations, and have had a number of partnerships in the UK from private insurers and corporates, but very importantly with the NHS. And in fact, we run something called GP at Hand, which is the largest GP service in the UK, and with over 100,000 users now using our service, and that is obviously in partnership with the NHS. We then set up in Rwanda in 2016, which is what Siobhan will talk about in a minute. And from there, both our service, our number of partners that we work with, which range from governments to insurers to hospital systems, that has grown. And we have, as has very much our product and service has evolved and grown over time. So we are working across Southeast Asia with Prudential Insurance, in 11 countries in the APAC region. We're now working in Canada with TELUS Health, and expanded into the US as well. So we have a range of geographies as well as types of partners that we work with. Fundamentally, what we're trying to do and thinking about the user is really thinking about how we can address as many healthcare needs as somebody has in one place. So really taking this digital first gateway, so really the starting point being what we can do digitally over somebody's mobile phone to provide a user with as many services as we can via that device, which includes both proactive chronic care management, such as the areas of diabetes, as well as digitally managed care pathways when somebody has greater, longer term needs of care, and really all the way through to how we can support people pre and post operatively. So we've really built out this whole model, which starts from using our AI technology at the center through to virtual services and physical services, but supporting people both when they're well to stay well and when they're sick to address their needs quickly and effectively in a very high quality manner. What this looks like and feels like from the perspective of a user, these are sort of screenshots of what our mobile app looks like. And we have tools that, as I mentioned before, are thinking about supporting the individual when they're well. And that includes a health assessment, which is a snapshot of somebody's current health status. It's a series of questions that then give the user feedback on their level of risk based on a comparable cohort, same age and gender of that person, as well as really actionable recommendations on how they can reduce their risk. This then is represented in a digital twin. We have a tool to help manage more chronic care conditions. And then in terms of the sick care, we have a symptom checker, which enables people wherever they are to be able to put in their symptoms and get some advice and information about what their condition could be and what the sort of best course of action for them would be, through to virtual consultations, physical consultations, which is always going to be part of a healthcare journey. And as I mentioned, all the way through to supporting people pre and post operatively. So that gives you a sense of this really fully integrated journey that we have now been able to build for patients, working with a range of partners and clients across the world. So I'm now going to hand over to Siobhan, who's going to talk about what we're doing in Rwanda.
Thank you very much. Babo was founded in 2016 to help Rwanda achieve its main issue of ensuring that there's quality healthcare throughout the country. We so far have 2.5 million registered people. We have completed about 2.2 million registered users, and we do an average consultations of about 5,200 every day. We have a contract with the government of Rwanda that we signed in March of 2020, in which and it's a 10-year contract, which allows us to provide the services that we do. About 86% of the population is insured by the insurance policy that we have a contract with, which is the Universal Health Insurance Program. And we also have partnered with about 500 health facilities of the 506 health facilities in the country. And this is how it works. As you might be aware, the majority of the African populations, while they are connected and have mobile phones, the majority of them do not have smartphones. So our service works on a feature phone or any phone that somebody has. And this has been adapted for the context that we're operating here in Africa. So how our service works is that somebody uses whatever phone they have, dial 811#, using a USSD application, and seek for an appointment. You would first register with us, seek an appointment with us, and you're seen by a triage nurse. A triage nurse will call you and find out what is the condition that you're suffering from. Majority of conditions are conditions that we can treat, but sometimes there would be conditions that would not be suitable for digital health. If it's a condition that is suitable, then then the nurse makes an appointment with a doctor or a senior nurse who can do a complete consultation with you. The doctor will call you and complete the consultation and give you advice like you would in a physical facility, or make prescriptions, send you a prescription code that you'd get via SMS, or a laboratory test that you'd also get by SMS. You'd then walk into a health facility of your choice and be able to pick your medication or to do the relevant tests. Once you have done the tests at the health facility, the tests are sent back into a system in which the doctor or the senior nurse can complete a consultation that they have done with you. In about November of last year, obviously during the pandemic, we've played a significant role by supporting the home-based care solution that the government suggested. Majority of patients, obviously throughout the world, over 90% of patients do not need to go to a physical facility. So for those who are staying at home, we work with the government to take care of these patients who are asymptomatic or mildly symptomatic, who we then take care of. A Babo staff supervised by a GP will call the patients every day to monitor their symptoms, provide information, and provide records on this program. So on a daily basis, the patient is also sent SMSs to be able to do, and it's a two-way SMS for the patient to tell us how they're feeling. And only when required, do we then send the patient to further care at a physical facility. During this process, or when we are doing care, we could give prescriptions to the person when it's required, and only when it's necessary do we then send them to a physical facility to take care of. We look after all the COVID patients that are at home, and we look after them until they test negative for COVID-19. This is the support that we are providing for the government. But in addition to this, for the services that we provide for, is that when we treat people digitally from home for any conditions, even other than COVID, then we are decongesting the health facilities that should focus on the really critically sick, especially during this very trying time. In Rwanda right now, and in a lot of the African continent, we are now going through another skyrocketing phase of COVID-19, where there are so many cases and very many hospitals are currently stretched. So this is the support that we are providing at the moment. Next slide. This slide shows the partnership that we have with the government of Rwanda. One, we talked about the 10-year contract we now have with the government of Rwanda. But as you know, healthcare is an ecosystem. You can't do it alone. It works within the whole ecosystem. So we have a relationship with the National Identity Agency, where we identify the agents that where we identify the patients so that we are treating the right patients. We have a relationship with the Ministry of Health so that if somebody is treated digitally, they can go to a laboratory test or a pharmacy and get their medication or laboratory test from those places. These are also paid for by the Universal Healthcare System in Rwanda, which is the relationship we have with the Rwanda Social Security Board, which funds both the consultations that we do, the prescriptions and the laboratory tests using the Universal Healthcare System. We have close collaborations with the Ministry of ICT, the Rwanda Development Board, and all our other partners, including the mobile providers, network providers, private pharmacies, and private insurance companies as well that use our services. Throughout this period, we have done a number of surveys, and one of the surveys actually done by an external party, which was Dalberg. And we found that 95% of our patients would recommend our services. 89% were satisfied with the experience that we have. In terms of quality of access of service, digital health has benefited patients equally in Rwanda. Both men and women are likely to use our service, and patients from all age brackets are also able to use our service. In terms of speed of access, 83% of patients finish their consultations within the hour, which you compare to a physical facility, which is only 33%. 85% of patients score us at 4 or 5%, at either 4 or 5%, for ease and accessibility of our service. And 94% have rated their clinical consultations are rated about 94%. Next.
So when we think about the technology and service that Babylon has kind of evolved globally, we're constantly looking to evolve and enhance what we do and make it further sort of affordable and accessible for our users and patients. So in the particular context that Siobhan has outlined, and obviously you've already heard about the sort of the adaptations that the team have made to make this work and make this really have sort of national level coverage and integration with the public health system in Rwanda. We also want to see how we can introduce some of our AI tools in Rwanda to further make healthcare affordable and accessible. So what we're doing at the moment, our AI model, and in this case, we're referring to our symptom checker that I talked about in one of the earlier slides. We've taken our model, and it's a model that is now being used in 17 countries and that we've localized for a number of contexts. We've now localized it for Rwanda, and that means localizing the epidemiology, localizing the language, localizing the care pathways, and making it appropriate for the culture and environment in which that service is going to be provided. And our first point of call will be to introduce it into our call center, where Siobhan's team of nurses will use it as part of their triage flow, which we believe will help to improve the efficiency, the consistency, and quality of what we're doing. And the second phase, which is a project which is being funded and supported by the Bill and Melinda Gates Foundation, is for us to take this tool and to use it in a trial in a number of public health facilities in Rwanda, to see whether this tool can really help to support and ease that congestion that Siobhan mentioned, which, around the number of people who are going into health centres, the efficiency of triage, and to support people to have access to our service as well, which obviously they are entitled to through the Mutuelle scheme. So this is a project. It's a new use case for us of our AI technology, but we feel is a really appropriate and exciting adaptation that we can do to make healthcare unaffordable in the context of Rwanda specifically. And in everything that we do, we're always keen to strengthen our understanding of how digital health can be used to transform clinical outcomes and healthcare. So we are continually building the evidence for digital health, and Siobhan has mentioned the study that Dalberg did of our work. We're now entering into a phase where we're having, in fact, an independent impact evaluation that's being led by the Rwanda School of Public Health to really look both at our service and the user experience and the effectiveness of what we're doing, but also look at the wider circumstances in Rwanda that has led to this very successful adoption of digital health as part of the suite of tools that are available within the health system to really address healthcare needs. And as an organization, we're constantly disseminating and engaging in this very vibrant sector, which is digital health, to really make sure that we're sharing our lessons and our experience with others in the sector to really help to see how really digital health can really fulfill the opportunity that I think it does provide to really address some of the most serious needs of healthcare and the serious challenges of healthcare, particularly in the context that we're talking about here, which is Africa. And I think with that, we would like to obviously thank you for listening to us and for giving us your attention. So thank you very much.
Thank you.
And here are Claire and Siobhan now to answer your questions. Welcome to you both. Thanks for that presentation. Claire, I'm going to come straight to you with a question. You mentioned the platform and the fact that data has to be inputted from the patient. How accurate is that data, given that, for example, if you were asked a question about your pain threshold, some people's pain threshold, is 9 out of 10, and some people are 2 out of 10. When you step on and off the scale, sometimes you get different measurements for weight. How can we be sure that that's accurate?
So we have a huge team of data scientists, clinicians, engineers who work on our model, who are constantly evolving it, constantly learning, testing. And this is something that they've kind of refined, and they've really kind of understood how kind of users engage with these types of tools. So this is it's constantly evolving process, constantly tested and checked, very high levels of security and safety. But it's something that I think the whole sector continually learns about and really understands kind of how individuals engage. So I would say we have a lot of confidence in what we do and how our users use our tools and products.
And with that, if people are using your tool, it takes them away from Dr. Google, as we call it here in the UK. People trying to self-diagnose and coming back with quite a lot of different answers, and often quite worrying. You can have a headache and think that you've got a brain tumour, and all of a sudden you're going down the wrong path, aren't you? So this is a potentially a safer way to engage.
Absolutely. It's about providing people with a really kind of curated information and advice. And obviously it doesn't replace needing to see a clinician. It's just giving people that sort of initial kind of reassurance and information when they are at home or wherever they are, where they have their mobile phone, to give them sort of a bit of sort of reassurance and guidance and recommendations around when it is the right time to escalate to speaking to a clinician. And it is, as you say, we are in a world where people have access to a huge amount of information online, and this really helps people to funnel them to much more accurate and safe information. Brilliant.
And Siobhan, congratulations. It sounds like the rollout in Rwanda is really going well. It seems like there's been a high take up, but there must be some challenges, I would imagine. You mentioned there, not always using smartphones, but using text phones. Do you come up with much resistance or challenges from people, say, who maybe struggle with dyslexia or maybe have dementia and aren't quite sure about using the technology? Maybe age is a barrier. I'm thinking of my own parents who are both in their 90s.
So what we have done, because we know that adoption is a challenge, we've decided to involve agents to support the system. And obviously, not only the issues that you have mentioned, there's also high illiteracy, not just literacy, but also digital literacy. So one of the things that we do is that we have hired a couple of agents in some of the health centers that we work that will take you through the system of accessing our care. So if you choose to use our platform, they'll say this is how you dial 811#, this is how you seek for an appointment. But the real issue is to personally teach you how next time you don't need to come to a health facility, next time you can stay at home, and this is how you use the service. And this is what we consistently do to sort of see how many people can now use the platform on their own without support. So in about 2019, the percentage was about 10% of the population. 10% of the people that are calling us, and that number has grown to 38% of people who are individually able to consult with us without any help. So yes, these challenges are there, and there's so many challenges that come across. But the plan is to sort of say, identify what the challenges and sit as a team and say, what is the solution to this particular challenge? And I think that's how you get the milestone as you go along, sort of addressing challenge by challenge as they come along.
Sure, and often it takes something like a national pandemic or a war or a famine to accelerate the take-up of some of these innovative ideas, doesn't it? And in your case with COVID-19, certainly in a lot of the areas that I hear about, people were positively discouraged, couldn't go to a doctor's or a medical practitioner. They were told to stay away. And so your technology really steps in there, not least of all because it helps with distance for people who are, perhaps not able to travel, people who've got young families who can't get out the house. This has got to be a breakthrough, hasn't it?
Yeah, and we've seen that increase in terms of our numbers. So before the pandemic, our uptake was high. And on one of our products, the numbers in the first lockdown in Rwanda grew by 155%. So the uptake grew by 155%, and that is really responding to the question that you're stating. People were discouraged to go to health facilities and so on. And right now, actually, I don't know whether a lot of people know that we are going through another wave in Africa. And so we're going through another set of lockdown and so on. And now we are really, really busy at the moment, because, for people who are not going to health facilities and so on. But also, one of the things that we're doing is we see ourselves as a preventative role, because in Rwanda, we know that the healthcare system is fragile, and there's so many things that the measurements that the government has put in place to sort of distance and so on, so that you don't get infected. And our role as Bubble as well is to make sure that when you're not feeling well, we treat you from home. So we even actually have a program with the COVID-19 program where we look after patients who are calling from to stay at home so that they don't go to the health facilities. So two things. One is that we're supporting the COVID-19 patients themselves, but also by treating people from home, we are decongesting the healthcare system, which really should concentrate on those who are critically ill.
Yeah, and I think that's the same worldwide. Claire, you probably are familiar with that weight tone. You are number 36 in the queue, or bounce backs. And is this a resource-intensive app? I mean, if there is a nurse involved at the other end, then they've got to be available to take the message and then respond to it. Are we going to have to increase the number of nurses and healthcare staff?
Well, I think Siobhan's team, really, they've got a very well-structured and well-managed team where they're able to kind of respond to people's initial calls very quickly and actually have a very good system. But I think maybe, Siobhan, you can talk a little bit about kind of how you're managing the resource that you have and your ability to respond to the increasing number of patients.
So we hire about 130 doctors and over 150 nurses that work with us on a part-time basis. And so we every day look at the numbers, looking at the previous day, looking at the previous number to see how many we can schedule. So when the volume increases, we increase the number of people that we need to do the consultations. So basically it's we are able to then say, to use the resources very well, to then say, if we are thinking we are getting X number of consultations, then we need X number of clinicians to be able to look after them, to make sure that a person is responded to within 30 minutes. So it's a calculation that we say, if you're going to respond to somebody in 30 minutes, how many clinicians do we need to know, do we need to be able to get to that result? And there's a whole team of people whose job is to monitor that.
And I mean, the potential is incredible here. Does the technology exist? So, for example, if I visited the doctor, you know, they might say, well, I need to listen to your chest, or let me test your blood pressure or your heartbeat. I'm sure, I don't know whether, Claire, you know the answer, or Siobhan, you know, is whether there's going to be a widget that you can stick on the end of your finger, plug into your phone and get that kind of information.
So for us, sorry.
No, go ahead.
Maybe let me, and then you come in after. So for us in Rwanda, we are connected with the healthcare system. So where if we do a consultation with you and we think that you need to go and do a laboratory test and indeed, you know, go test your pressure and things like that, we do have a relationship with a health facility where you can go and then do the relevant tests. And then these tests come back into a system, and then we can call the patient and complete the consultation. So that's sort of, I mean, it's an ecosystem, and you know, we do have relationship with the physical facilities, laboratories, and so on to be able to do that. Over to you, Claire, if you want to add something.
And just to say that I think there's a lot of really exciting opportunities coming in the future with more self-testing and point-of-care diagnostics that hopefully, you know, our system and others will be able to integrate with over time to really provide an even more holistic service to patients in their community.
Brilliant. Well, and perfect timing there, the pair of you. I know that you have to go off and do some work of your own. Thank you for joining us. It's fascinating stuff, and I'd be if we were having this conversation in 10 years' time, it'd be incredible to see where we're going to be, because the pace is accelerating, well, at a pace, so to say. But for now, thank you both for joining us, and that is Dr. Siobhan Boyamakama and Claire Morris. Thank you both.
Thank you
very much.
If you want to watch that presentation again, you can go to the Future Health YouTube channel, watch it again there. If you want to carry on the conversation, of course, you can use the chat facility on this brilliant platform that we're using, where you can also network. And for those of you that enjoy social media, use the hashtag. Go to Africa Health Week and also Future Health on LinkedIn, Twitter, Facebook, and join in the conversation there. And talking of conversations, we will be very shortly in conversation with Mark Gregory. But before we ask him some questions, we'll go to him very shortly. Just to let you know, Mark is CEO of Ollie Health. And what he is going to say is all about mobile healthcare currency for the remote workforce. Here he is now.
A huge welcome to everyone that is joining my talk. I'm Mark Gregory Knowles, and I hope that you have a strong cup of coffee. I understand that virtual conferences can be a little bit different. They're not the same, but I promise that I'm not going to throw statistics at you or technological jargon. I really just want to take you through our journey as a team and what we think is the future of healthcare service delivery and how we're building a mobile healthcare currency here in South Africa for the remote workforce. There's a Zulu battle code called Impi, which implies that no chief can send out a soldier into battle without a weapon. Now, considering that the Zulus were incredibly innovative, They had shorter, larger weapons that allowed them to be more mobile and more flexible. And I think that there ought to be a similar specification for the youth and students on this continent, that we arm them before they go out to study, and that before they join the ever-adapting workforce, that they have access to primary care, that they have access online to healthcare providers that is on demand and that is tailored to them no matter what, no matter where they are in the country or in the continent. And this is because your success in life is largely due to your mental and physical health, how much you can build and contribute to the community, and the quality of your ideas, the quality of your decisions, in that order. And the first step is allowing access to primary care to the youth of our country and to the youth of our continent. But in reality, we have a massive healthcare scaling problem. In South Africa alone, 80% of our population just doesn't have access to primary care and private primary care. Our public healthcare systems are incredibly overloaded, and the way that the system is designed is complex. There's third-party insurance and medical aid providers, and a lot of these medical aid schemes were designed 15, 20 years ago to sell to big corporate companies that would then cover these packages. But companies don't do that anymore, and as family budgets shrink, a lot of people don't have access to these medical aid schemes. And we believe that there needs to be a more direct, more technologically focused solution to this problem. If we look at healthcare today, it's incredibly limiting. If I'm a worker or a student, I have to take 1 or 2 hours out of my day to catch transport, to go to a physical clinic, to be in a waiting room that is often overloaded. And this process is incredibly limiting. If I have access to a public clinic or a private clinic, I'm also having to pay upfront cash if I'm not on a medical aid scheme to access a once-off appointment with a primary care provider. And this is how we see healthcare tomorrow. What we call a productized currency. This is a completely new concept in which we take the new service model of healthcare to the mobile generation. Now, if I'm completely honest with you, telehealth alone and technology alone won't drive change. We need to create new service models that deliver healthcare in a way that is scalable and has mutual transactional value. And what we are creating at Ollie is a simple model where an employer will get paid a small monthly fee to join the platform as a member. And being a member means that you get access to these credits. And these credits you can redeem services on the app, from an in-person appointment to a physical appointment. This becomes a new currency in which you get credits upfront. As a patient, you are never having to think, do I have cash to go to a general practitioner? Do I have access to a mental health practitioner, but I don't know where to start, and I don't have the continuous budget to go for 1, 2, or 3 mental health sessions, which is what is required to have a sustainable diagnosis, or even just support. As we've seen with remote work, the burnout levels are incredibly high. And as a 23, 24-year-old joining the remote workforce, it's incredibly stressful. You have a support system of one. We call this a productized internet native currency. And we believe that this transactional value will actually open the access of healthcare for the younger generation. Now, if we look at mental health as a category and a use case for telehealth, I think it's vital to understand the immense amounts of pressure that there are on young workers and students. If we look at the statistics on how much mental health is mentioned in earning reports, it's unbelievable post-pandemic and mid-pandemic, the importance that is being placed on mental health. Employers are burnt out, and the access to mental health, there's a massive stigma, whether it's cultural or whether it comes from your family, around mental health and the support that you can get. Now, growing up in a house of 3 women was definitely interesting, and a few of my family members have struggled with mental health issues, and I never really understood it until I decided to take the massive leap and go work for some startups up in Toronto, Canada, in the depths of winter. coming from South Africa by myself, going up to a completely different climate and culture. The startups there had a 996 principle, which was you start work at 9 in the morning till 9 at night, and that's 6 days a week. I believe that's taken from a culture that originated in Hong Kong. And, you know, it was after months of this work and little interaction with anyone around me that I really understood the importance of having someone to talk to. And I realized the mental health struggles and how I wish that I had instant access to someone that can support me. And I think that is an incredibly important point that we want to drive home here, is that a mobile platform will allow for more distribution for young people to access on-demand mental health. You never have to worry about, do I have enough cash? Do I have upfront cash? Do I need to claim back to book this service or appointment? It's an on-demand service where the credits get redeemed within the app. And on the service provider side, whether you're a GP, a psychologist, or a therapist, it's a new form of revenue where you get paid out directly for that booking. And it actually becomes a whole new service model for you as a practice of one or an entire clinic. Now, we understand that we have a long way to go, but if we zoom out and we take it Africa, its scale is incredibly amazing to grasp. I mean, the whole of Europe, China, the continental United States, and India can fit into this continent. The population size is unbelievable. We have a massive and powerful growing middle class. But we do have capital allocation challenges. You know, in fintech, you often see bank the unbanked, but I believe that the problem isn't a technological problem. The problem is you can't bank the unbanked if they don't have income, if they don't have health to get income. And I believe the challenge is the same in healthcare. You know, the technology itself isn't going to drive any meaningful change or adoption. We need to have a completely new system and way that patients can easily access and are incentivized to access mobile healthcare that's sustainable, that they can build data as they grow and as they understand their healthcare needs. I thought this would be really, really interesting to include and perhaps conclude on, is if we look at the ecosystem in South Africa, our company's just closed a pre-seed round, and I know how incredibly difficult it is to raise capital as a medtech startup. You know, if we look at raising capital in other parts of the world, the capital allocation is just vastly different. And although this is growing in the first sector of 2021, the amount raised over 12 months is at 77.1 million USD, which is still about 1% of where this capital allocation can be for us to have empowering teams to build and challenge new types of technology in the space that provide mutual value for the patients and for the providers. Thank you so much for listening to my talk. I hope that you walk away from it thinking of technology not as an incremental improvement to your practice or to your everyday life, but rather the directional arrow of progress that Africa as a continent is moving towards, and how technology can completely rebuild the healthcare delivery network, and how a currency can actually incentivize mobile access that is more affordable and accessible from the comfort of anywhere in Africa.
And here is Mark now. Hello, Mark. Where are you today? Hey, Mark. I think we might have missed that one. Can you just say that again? Where are you today?
Yeah, sure. Hi, thank you so much for having me on the Q&A. I'm working from home remotely today.
There you go. So you're the perfect example of what you were talking about in your presentation there. I'm not sure I quite understood or heard that funding method, if you like. So refresh us. Did you say that the employer joins the platform as a member but receives a payment for that?
So how the system works is very simple. A company, let's say if you have a team of 25 members, the company will then give the employees access to a membership. So it's a small monthly fee between 300 and 500 Rand that they pay for each employer. And then that employer then gets access to all of the credits up front, whether it's for 6 months or a year. Then they get access to those credits, which they can immediately use to book an appointment and redeem on the mobile app.
And do those employers come to you readily? Is there any resistance?
I think we've seen a huge kind of shift towards how can we give employee benefits, especially to remote workers, and but there's kind of a mechanism where it's either old organizational kind of employee benefit structures, which can be quite complex. So they're looking for something that's flexible and, of course, affordable, and something that can drive the overall bottom line of the company. But I think we're seeing not just HR managers, but company directors are incredibly more empathetic towards burnout and the need for their employers to have some kind of anonymous support system where they can try alleviate organizational burnout. And that's really what we're trying to provide, just something that's easy and accessible for companies.
And I think there you're absolutely right, where employers are seeing the benefits, aren't they? They don't want their staff to be unwell, they're not productive, they may take time off. So it's in their interest, isn't it, to make this investment to ensure that their workforce is happy and healthy, both physically and mentally.
Absolutely. And I think companies have seen that weren't remote first. As they made the shift to remote, productivity actually increased, which was amazing and a huge surprise to a lot of bigger companies that thought it would be a massive challenge. But then I think over time, the realization of, burnout and mental fatigue and the lack of connection between employees, your company is your team. And I think the value of that, there's a global network of employers. And, I think the ability to retain your employees is going to be increasingly more important. And to give them access to primary care is a mechanism that they can help retain employees.
I think a lot of this really came into focus, didn't it, during the COVID-19 pandemic, when people were encouraged to stay at home, even told to stay at home, that some were told to carry on working. And at first, you would think that would be a bit of a dream. Oh, I can just wander straight from my bed to my workplace. I don't have to commute. But you've highlighted there that over time, there are elements that you miss. You miss the interaction, you miss the camaraderie, maybe just talking to a colleague over the water cooler about an issue you might be having. And so some of those services that you're seeing paid for are the ones that perhaps are most in need because of what's happening in the world.
Absolutely. And I think, we want this access to primary care to be not just about diagnostics, where, a lot of employees, they're not reaching out to mental health professionals or going to a GP because there's a stigma around, well, I don't suffer from depression or I don't have a chronic disease. But we want to actually have a system that supports you and acts as a support network where it's not just about diagnostics, but it's about continuous support. And, our vision is that we want to have employers have instant access 2 to 3 times a week throughout the entire year to have that conversation with a mental health practitioner or reach out to a GP. So we're incredibly excited to build and develop the product to access more and more people in South Africa and Africa eventually.
And quite often, I mean, you mentioned there, about a reluctance maybe to come forward and say you have a mental health issue. That quite often affects men more than women. You highlighted that idea of growing up in a household of women. And actually, those initial conversations are probably the most important, because if you leave it too late, then you really do struggle, don't you?
Yeah, I think it's coming to terms with the fact that you're working hard, especially if you're working in a smaller team, a startup or a bigger company. There's just a lot more pressure to perform. The pace of work is increasing, which increases expectations. And we're all human, and I think if we can help. It's not just good enough to educate people on breaking that stigma of reaching out to a mental health provider, I think we actually have to design a new system, something that incentivizes people to really take responsibility and make it feel like this is a safe space outside of your work to actually have these conversations. You can use these credits and you can actually build, data over time that's going to be incredibly valuable to you and your employer.
You mentioned there the 996 working pattern. For a lot of people, they feel like it's now become 24/7. With technology comes some sort of urgency. You get an email, it might be 11 o'clock at night, you feel like you have to respond to it, especially if it comes from your boss. What would you say to that? Do we need to change our thinking around this culture?
Yeah, I think a large part of it is to blame. The tools get blamed, Slack and notifications, that little green symbol to make sure that you're always online. Even if you're making a cup of tea, you quickly move your mouse to make sure that you're online. I think those behaviors, over time, it needs to come from the top down. It needs to come from true leaders and managers in the organization, that it's still about building output and creating value. It's not just about being the fastest to reply. I think the tools aren't necessarily to blame. I think the culture comes from the top down. And if a company can say every member in this team is important, your mental health is important in order to produce great work, truly amazing work, and by offering these services, we believe that hopefully it'll kind of promote a new type of workforce culture that is not just obsessed with performance and data, but actually building meaningful relationships and a positive work culture, whether that's fully distributed, fully remote, or at the office.
And I guess it's about those leaders, as you say, senior managers and the others, that two things really, I suppose. They've got to trust people. Because quite often, certainly in my era, everybody had to go to the office because then we knew where you were, and we could keep an eye on you. And it felt a little bit like that. So there's a trust issue, but also understanding individuals. Some people work better in the morning. Some people need a nap at lunchtime. Some people are better working in groups and they get more creative. And I guess, especially with a remote workforce, you've got to grasp all of that trust and individual needs.
That's an amazing point. One of the questions, we found that we need to ask kind of better questions instead of saying, what is the deadline, or when can you have this done by? We often ask members in our own team, if you had to have an ideal day and you had to put aside 3 to 4 hours, what would that mean for you? Is that getting up at 6, going for a walk before and really getting into deep focused work? Is it more in the evenings, once you've dropped the kids off at school or you've picked them up, you've spent time with them? I think it's completely kind of subjective to how that person incorporates that workflow. And I think by asking those questions just from the start, I think we can kind of set a better culture.
Yeah, and get the best out of people. And as you say, move forward together. I think there's a lot of traditional work practice that have to be dismantled, aren't there? An education then process of leaders about how things can be different, especially because, as young people come through, they have different ideas. They're questioning, aren't they? More and more, they're disruptors. They're saying, well, why does it have to be like this? Why? I see workplaces now that have got beds so that if you're tired because you had a late night, you can go and have a sleep. But if that makes you more productive in the hours that follow, there you go. Whereas back in my day, you'd be sacked if you were found sleeping in the toilet or something.
Yeah, absolutely. And I think, this remote work culture, we see it as Africa's gateway to the world. I think that we have amazing young talent, but, we need to find a way to switch on a revenue stream and a salary for young talent. How do we do that? Distributed work will give access to a lot of African kind of young talent, access to working for a company in the States, the US, Europe, which will be incredible. But I think the fundamental question of, they're not going to be covered by health insurers, especially if you're working for an international or a local company, that system has completely changed. So we know that if you're going to do your best work, you have to have primary care. You have to be willing to put your health first. And that's what we want to try to provide is essentially a new type of medical insurance that it doesn't matter where you are or who you work for. This mobile platform is going to be there for you to make those appointments.
And presumably for young people particularly who are looking for careers or new jobs or workplaces, this is an incentive, isn't it? So if I see that as a reward and I'm a young person, and it is a reward and an incentive, so some might say, oh, as part of this career move, you'll get a free gym membership or access to a company car or whatever they say. If they say these credits are available to you through the company, that's a massive bonus and an incentive, isn't it? Or it should be.
Yeah, I think, when I was working in Toronto, there was certain types of, rewards that you would get and free lunches, free meals. I think in the tech environment, it's incredibly competitive to get really good quality software engineers and programmers. And so, those type of rewards were very much surface level to attract employees, where I think these type of benefits are actually meaningful. That are actually going to showcase that you as a company, you care about the health of your team. You know that your team is what's going to drive success. It's not just the fact that your team is 24 hours all on and can work from 12 different countries and it's diverse. It's the fact that your team can work together and connect because they know and understand that they always have access to a doctor or a mental health practitioner. And I think that kind of level of security can allow you to put in your best work.
You say that they'll always have access. I mean, is it really unlimited, or is it that, again, using another, I'm going to sound like a really old fuddy-duddy here from my era, is that, for each year of employment, for example, in one company I work for, you get an extra day's holiday tagged onto your annual entitlement. So will more credits become available if you get promoted, if you've worked within the company for a long time, or is it equal across the platform and you can have unlimited use?
It's completely equal across the platform. So whether you're a senior manager or you've just started at the company, you will get your credits and you'll get them up front. So you can choose how you want to use your credits. And if you want to use them exclusively to see on teletherapy, for example, you can do that and it's anonymous. You have your membership, what you do with your credits, how you redeem them. It's not you don't have to request credits from your boss. They're not seeing, how many sessions or how many hours a week you are on a telehealth call. It's completely anonymous and you have that discretion to take control of your own health.
And I think that's really important, isn't it? Because despite what we want to happen, people do judge, don't they? And they'll say, oh, he's always on the phone to this service. There's something not quite right with this person. It's awful, isn't it, to say, but that is the reality with some managers.
And I mean, how many sick days are people redeemed through the height of lockdown in the pandemic? A lot of companies have seen 0 sick days being redeemed. And that's because they're too scared to request even 2 to 3 hours out of their day to not sit on a Zoom call and to go to a doctor. And we're hoping that we can change that behavior.
Yeah, I think you're absolutely right. Certainly when I started working from home, you just trudge on because you can sit there in your pajamas with a cold. You're not infecting anyone and you're expected to be at work. But I guess that needs to change as well.
Absolutely.
And the data is safe. There's no danger to the data because obviously people are worried about hacking and being held to ransom with all of this.
It's safe and secure. It's not a decentralized network, but we do store it safely and securely locally here in South Africa.
Brilliant. Well, listen, what you're doing sounds amazing. I wish I'd had it in my earlier career. So well done to you guys. Keep up the good work. Thanks for joining us. And well, for now, wherever you, where are you in the world today?
I am in the Eastern Cape in South Africa.
There we are, in the Eastern Cape. Great. Well, listen, what you're doing down there and for all of Africa is brilliant. Let's hope there's great take up on that, and we'll speak to you soon. Thanks for joining us.
Thank you so much for your time. Thank you.
That's Mark Gregory from Ollie Health. Brilliant innovations that we've heard about, not just today, but over the full 3 days of Africa Health Week. Some tremendous ideas and services that are being provided, things that are being thought through. And it really does feel like Africa is at the forefront of some of the best practice. And that is, of course, what this week is all about: sharing best practice, ideas, educating, learning from others, and growing a network, not just in Africa, but worldwide, of healthcare professionals, people who are interested in our and your well-being and healthcare, so that we're networked throughout the globe, talking about these important issues, making changes so that we can all progress in the future. So there we are. Well, we've had a brilliant morning. We've got a fantastic afternoon coming up for you as well. 2 more presentations to come after lunch. So we'll be back shortly. Enjoy a break. And we'll see you back here in around about an hour. Welcome back to the final couple of sessions of Africa Health Week 2021. I'm Dave Sharp. I'm your host and moderator as we move towards the close of play. We've been here now for nearly 3 days, and we've had some inspirational speakers, some terrific content online, and you can see that all again. If you've missed any of it or you'd like to go on catch up, just go to the Future Health YouTube channel. Those sessions will be there indefinitely for you to have a look at. If you're on the platform and you want to talk to each other, you've got the networking opportunity, you've got the chat, and of course with any of our presenters you can use the Q&A to ask your questions, and if you want to nudge them up the pecking order, then all you can do there is vote on them. That's why we're here. We're here to learn, to innovate, to challenge and to inspire. We're here to come together to share knowledge through not just our speakers, but you people as well, wherever you are, at home, in your offices, wherever you are in the world, but certainly wherever you are in Africa. We are going around the globe with the Future Health Series events. We've already been in the Arabian world. We've been in the UK. We'll be heading to the USA in September and beyond, uniting the world in a global cause to improve healthcare services and to create and develop this brilliant community of professionals. Those professionals, of course, are you. If you want to stay in touch beyond this event, or if you want to comment right away, then just use the hashtag Africa Health Week or Future Health. We're on LinkedIn, we're on Twitter, we're on Facebook and the usual platforms. So 2 more sessions to go. You will be able to continue on the platform tomorrow. It's open for networking. But in terms of the presentations and the speakers, we're into the last couple, and coming up this afternoon, you can see the following people. Here we are. We'll be talking to Andronica and Yaku very shortly. I'll introduce their session. And then to finish off, Saul Cornick will be with us talking about escalating private healthcare costs and how that can be addressed and challenged. So our next session is all about knowledge sharing and transfer of non-technical skills. And to tell us more about that is Andronica Maseki from the Fila Health Organization. She's the co-founder there, and she's joined by Yaku Badenhorst, who will open the presentation. Here they are now.
Hi, everybody. My name is Yaku, my colleague here, Andronica. We are from Fila Health. Thank you for the opportunity. We would like to, we are very excited to participate in Africa Health Week. Andronica, I think I'm going to start with just giving a quick background of Fila Health. It's a young startup. And we look at health workers who provide care services to their communities. Now, our vision is to provide a convenient and affordable access to health workers in the community. And we focus on improving health well-being and encourage proactive, healthy living. Now, our mission is to transform the community healthcare industry by reducing the cost and by improving the quality of the care services offered by autonomous groups. Now, let me go into more detail on that. I want to first bring 4 things that I think most of us can agree on related to healthcare. The first is that every person wants control over their own lives and over their health. The second is that most people want to maintain or improve the quality of their life. Most people want to respectful integration and comfortable relationship with their healthcare providers, and most people want accessible, convenient, and affordable healthcare services. Now, if we can all agree on that, then we've asked ourselves, how can we improve the medical care industry? Because we believe the problem is that care became a product, and the patients became clients. This is what needs to be addressed. We believe the solution is, number 1, reduce the cost of medical care by removing management levels and reducing administration fees. And the second is to improve the quality of healthcare workers by healthcare providers that are passionate about caring and looking after sick people from their community. Now, as I said just now, we believe that autonomous groups who give care in their communities, that for us is the solution. And that is what I would like to go into more detail with this panel and to share with you. Now, if you look in South Africa, the franchise model, it's been very successful. South Africa is on the forefront in Africa. And looking at the franchise model, but also we got our inspiration from a company which is called Buurtzorg. Now, this was founded by a gentleman, he's a nurse himself, Jos de Blok, in 2006. Now, this Dutch home care organization has attracted international attention for its innovative use of independent nurse teams in delivering low-cost care. Now, the company employed 10,000 nurses and 4,500 home help workers in 2018, and the concept is now being adopted in 14 countries, including Sweden, Japan, UK, and in the United States. Now, this model of community nursing is widely cited as a promising approach to improving the delivery of integrated nursing and social care in communities. And the model is characterized by high level of patient and staff satisfaction. Well, in short, it provides effective, high-quality care at a lower cost. And that is exactly what Phila Health strive to deliver. Now, we believe the success of this model are changing the healthcare industry. But Africa is still lacking behind. So Phila Health strive to bring us closer to these ideals. Now, before I go into examples, I would like to first move over to my colleague, Andronica.
Thank you, Jaco. Hi, everyone. We are very honored to be here. As Jaco has said, we are a startup. The research has shown that healthcare, there are gaps in the healthcare, and people want better healthcare service. And one thing that comes, into our mind is, how do you provide better service in healthcare without your staff members having soft skills? And which is something that is lacking in a lot of healthcare centers or institutions. It's something that, it doesn't really resonate when people think about nurses or doctors training. But it's very, very imperative that we address that. And that's where Phila Health also contributes at. And if you look at the demographics of most African countries, culture is very, very important. And we have to make sure that the environment that our health workers work in, it's conducive, and it makes a patient to be comfortable with what they get from the healthcare workers, being in terms of communication, being with the healthcare worker, being able to listen and understand the backgrounds, the culture of our patients. And that's where we are so concentrating on community-based workers, as my colleague Jaco has said. And we see the model that it will work, because the community workers are with the community. The community workers are within the communities, and they understand the culture around the communities. They understand the daily burdens or any influence that might make the patient's life easier. And also being able to communicate with with the family and the client and make them comfortable. And that in return makes the customer have better healthcare service. And this is part of where the health sector is going in terms of when you look at the model that Jaco has said, it's all about task shifting, where you use innovative ways of addressing the skills within the healthcare center and improving on them. I mean, this can also help with improving unemployment rate and getting it down, because you can have young people getting into healthcare without going to, to study for a long time. There are a lot of people who are passionate about healthcare, but they don't know where to start. And our intention as Pillar Health is to take them and pair them with very skilled healthcare workers that are working for us, and getting those skills learned by the trainees that are coming in. And this is very, very, very interesting for us, because we think that we've got a winning solution here. I will give Jaco to give some examples.
Yeah, well, Andronica, I think what excites us so is to be part of this Africa Health Week is for minds to get together and to talk about health. Health has become a very major issue. Since the COVID-19 pandemic, health is something that we constantly think of. And getting these minds together will find a way how to improve the care, the health of and especially in our continent, in Africa. Now, we believe if a person comes from a specific community, that person has got a special feeling for the people in that community. That person would know family, or know that person, the healthcare worker would know the patient personally or know their families, and the well-being of that person would be very important. So we believe a relationship between a healthcare worker and a patient is when the healthcare worker wakes up in the morning, send a WhatsApp and say, how do you feel today? What time shall I come around and wash your back? Now, these are things which people are willing to provide in their community. And we are moving towards an era where people will be looking after each other in that community. I'm very excited. I think there's a bright future ahead of us.
I agree with you, Jaco. And I mean, with the shortage of the skills that we have in healthcare, I think within communities, this can work. It's a working model because they manage themselves, they administer themselves, they are treated like a franchise. They, get best training from, the people within the community. They understand each other, they understand the environment. And then this is exciting stuff. And then I think Pillar Health will make a difference. And going further, we're looking forward to partnering with our African brothers and sisters who are passionate about the healthcare industry to join us, and let's make healthcare be accessible in Africa as a whole, and make it a pleasurable, feeling when you go to see a doctor or a nurse and you feel that, somebody cares. And this is where we are. And we are just saying, let's combine the knowledge that we have, technology, great minds within the medical industry. We are just, and Pillar Health is saying, yes, we understand that we need the skills in terms of medical skills, but let's give the opportunity to the young and coming youth that, around the world, around the continent, to be part of, contributing to the community in terms of health. And this can be a winning formula.
Yes, I agree. And things has changed. The health industry need to change. We have now the information is on the internet, We have connect various groups with each other and provide them with the knowledge. The knowledge is out there to provide healthcare, but also as you said, the technology, where we're now in a situation where a nurse can open a laptop and facilitate a consultation with a doctor, which can only take a few minutes of the doctor's time and does not require from that patient to go to the doctor's office. So many things changed, I think, and that's what is exciting, is that the health industry will also be changing. Africa has been very innovative. We have the largest mobile uptake in the world, and we have the opportunity here to go in new fields of providing healthcare.
I agree with you, Jaco, and I'm excited, to be part of this event. It's for me, it's something that needs to happen not only once a year, but maybe quarterly. We need this kind of of events so that we can meet up and discuss healthcare. It's one of the critical things that needs to change in the continent. We have to learn from countries like India, what they have done also in terms of health. And we have very, very skilled and very, very professional, skilled people who can, partner with us, who are, very passionate about technology as well, and change the healthcare industry to be a better solution for the whole continent.
And make everybody healthier.
Exactly. I mean, we talk about proactive health management, which is something that also needs to be, taken up. And especially when you look at rural communities and disadvantaged areas, and which is something that we are very passionate about. Know your health, know your status, be proactive when it comes to your health, and don't wait for for you to get sick as a patient and have to go to the doctor. And this is something that we have seen that it works, and we provide these services as well as Pillar Health, and it works in the communities. It lessens the burdens of long queues in the hospitals, and also we let the doctors concentrate on things that they can make better in terms of specialty, and let primary health care to the lower level healthcare workers. And that's what we are saying as Pillar.
Okay.
I
think that sums it up. Thank you for inviting us.
And here they are, Andronica and Jaco join us. Welcome to both of you. Thanks for joining us on Africa Health Week, and thanks for your presentation.
Thank you, Dave.
Thank you for inviting us.
And you spoke there passionately about the idea of Africa Health Week and spreading news and learning and bringing people together. And we're grateful for those comments. And you've come up with this model. Congratulations on the startup, by the way. It's always good to see people stepping out of their comfort zone and starting up these companies. You talk there a little bit about reducing costs by reducing admin, reducing management, and putting that money into your community nursing team. Is there a danger that those community nurses aren't seen with the same value? I mean, are they being paid, for example, at a good salary scale? They're not just a cheap option, are they?
No, absolutely not. We believe they should be well compensated, but providing it in this way reduces the expenses. If they need, for example, the consultation from a doctor, they log on to on a laptop, can log on to a doctor and get the professional assistance that they need.
And Andronica, if you've got a community nursing team, and you both talked about how, you know, that's almost a more user-friendly service, you know, knowing that somebody's round the corner rather than several miles away, knowing that maybe your daughter grew up with their son, and all of those interactions, because people are quite often fearful, aren't they, when it comes to healthcare. So nurturing that kind of spirit is important to the value of a community nursing team, isn't it?
It is very important. And if you look at how disadvantaged communities are in terms of the demographics, it gives you comfort to talk to somebody who knows, you know, what you're going through, what you're experiencing, and also it in terms of the language barrier as well, it helps, because we find that language as well, when people go to the clinics or the hospitals, there's a language barrier as well that, you know, gets in the way of explaining what the problems are. So if they're talking to somebody who is in the community, who understand the culture, who understand, you know, the daily struggles of everyone in the community, and also it's just a call away, and somebody is there, you know, within few minutes. Within South Africa, there is a high volume of people who go to the clinics. People will wake up at 4 a.m. and just to line up to see a doctor. So what we are saying is, if we can provide primary health care, you know, in this way, it lessens the influx of the clinics, and also people now they start, you know, caring about their health, because we also have partnered with one of the doctors who is very passionate about making healthcare reasonable, and there's an app that we use as well. So we've got tools. So whatever is at the clinic, when it comes to primary health care, we've got the tools that our nurses, you know, they can take a backpack and go to the local community, and they've got everything. And the people can get, if it's a chronic disease like diabetes or high blood pressure, it can be monitored on regular basis. They don't need to be at the clinic on regular basis. So that's what we are saying. Let's make it simple.
And yes, it seems like you're achieving that. Sorry, Jaco, you were going to say.
Yes, I wanted to add about this testing kit, the rucksack. Now, it's a kit, and we can do. Our team can do 27 tests from a bag which a person carries on his back. So it became very mobile to be able to do these important tests. And if you can do a test before you get to the clinic, you save some valuable time of the clinic personnel, you know already. But also these tests can also, you can evaluate the progress. You can identify problems earlier. So part of the community nursing project is also the ability to do these tests regularly at a very low cost.
Yeah, it's a great idea, and it makes sense. I'm shocked that you know it's seems obvious, doesn't it, that we should be doing this, and well done to you for making it happen. When you talk about community, do you have a ratio of one nurse per 10 families or 100 people? How does that work?
Basically, it's one nurse per 50 families around the area, and we expand as we see the need. We just started last year as per the pandemic started, and we saw the need as Pilar that we need to be on the grounds. And if you look at, we concentrated mostly on elders, because by now they couldn't go to the clinics, and they were in danger of COVID. So for us, it's convenience, and 51 nurse for 50, and also they work as a team. So it's a group of nurses that support each other, and they all have their strengths in the team. So there's one who's very, very well with, let's say, diabetes, who knows diabetes very well and how to manage it. And there's one who can, help with high blood pressure. So they support each other. And the nice thing about it is they can back each other up. When the other one is not available, the other one can go to the community. So it's a community-based team.
And I would like to add that it's not the amount of families, but the need. So this autonomous group, the franchise, if you call it so, can decide if they need more, they can get more people in their team, or they can, in a community, another team can start. So it depends on what kind of requests do you get from that community.
That flexibility is important, isn't it? Because my next question would have been around, how you priority. So if 30 of 50 families all fall sick at the same time, or there's a tragedy in an area, then you how do you prioritize the most important? But you're saying that you can mobilize very quickly to attack that need.
Yes.
Add more people to your team, or bring another team in.
Because there's each and every community has its own team. So if the other team is not busy, they can just help the other team. And also what we are looking at is empowering the youth and letting them learn from, the professionals already, all the nurses that they've already been in the profession. And this will also help us to, lower the number of unemployment in the country, which is a big problem currently.
Yeah, I think that idea of almost an apprenticeship where you learn from others, and maybe as well you find what you really enjoy. So if you're traveling around with somebody whose specialism is diabetes, you may think, yeah, that's what I really want to do, because as you say, young people often don't know, but they'll perhaps pick up on a specialism whilst they're doing more general work. Would that be right?
That's true. That's true. We are trying to encourage the youth as well to look at different areas of health. Primary health care is very, very important. And if you look at the ratios of a number of patients per doctor, I think in terms of, what we are doing also with the youth is task shifting, whereby you say those tasks that are done by the professional nurses that can be moved to somebody else who doesn't have much knowledge, but who has been trained with the help of technology. Like we say, we've got an app and the kit, and they can go and, test a person for high blood pressure and log it onto the system, and the system does the algorithm at the back, and then they get the results. That is, it's what we are aiming for.
Just a little thought of mine. If these people are in their community and they happen to be, traveling to see a neighbour or going somewhere within the community, and they bump into one of these people, is there a danger that they say, oh, hi, while I've got you, I've got this pain in my knee? and that person might say, well, I'm actually not on duty at the moment. How would you handle that?
It's a community effort. I don't know if you know about Ubuntu. So in Africa, there is Ubuntu, and one of the speakers yesterday touched on Ubuntu. So with us, it's all about, I understand, they understand, and then they will make an appointment with them. We accommodate. As Africans, we are open to, those kind of situations. So
Brilliant.
Our nurses are also, because they are part of the community, they know them. It's like a family. So they, they do take up those kind of questions, but they do like help at the end. It's not like you have to pay, or they can help wherever they can. It's all about community.
it sounds a perfect model in that respect, very human centered. And who monitors the standards? How do you do that especially in remote communities?
I'll let
Yeah, at this stage we are still fairly small, so it is something that we as we are scaling, we'll definitely more look at the standards. But I think the equipment we use are fairly standard. So it's a test, hardware which conducts a test and give a result. Those kind of things are standard with the equipment and the app which gives the result. In terms of the care, it is a community who works together, so they look at each other's standards. But that's something that we look in the future, how we are going to create a team who goes to these different teams, provide them with the necessary training, and look at the quality of care, see how we can improve on that.
And how are you looking to strengthen healthcare delivery in underprivileged areas? Presumably the same model works wherever you are.
I think for us, the aim is for us to have more strength is to partner up with the healthcare institutions, the public healthcare institutions, and we are here to say we are here, we can help. It doesn't help to just look at the government and say, you have to provide. We have to do something from the ground. And if we can get the backing from the government to understand where we are and to alleviate all the burdens that they have with technology, with innovation, I think we can reach those trends.
I think the way you've joined technology and community and involving young people is very important, and that sort of triangle of care seems to be very important.
It is very, because it takes somebody who has been at the ground level, who can see the struggles, who can understand what people are going through, to see what is needed. The government by itself, it can't, because they're not everywhere. So we are saying we have the ground workers on the ground. Give us an opportunity to help you, and with that we can. I think it can be. This is for us is a winning formula for disadvantaged areas and rural areas as well, because there is a lack of healthcare facilities all around, and this can be something that can be looked at in terms of evaluating, even having physical locations, because we are mobile. You don't need to have a physical location.
I think what you're doing is incredible. Anything that, as you say, reduces costs, increase accessibility, means that people don't have to travel. Certainly people don't want to get up early and stand in a line and then possibly still not get seen. So what you're doing, mobilising the community to care for itself, it's a great model, and I want to wish you both every success, especially as a new startup. Well done to both of you. It'd be great to hear from you in the future and see how it's going.
Thank you very much.
Thank you for inviting us.
Thanks for joining us. That's Jaco and Andronica. Brilliant presentation. So much innovation going on. So many ideas and knowledge that is impacting the health and well-being of people all across Africa and being shared now, of course, through this platform worldwide. So we've got one more presentation coming up. We're going to take a short break of around about 10 minutes, and we'll be back for our final presentation from Saul Cornick. Welcome back to Africa Health Week, the final session after 3 wonderful days. It's the closing Tech Talk session, and to present it is Saul Koenig. He's going to be speaking about escalating private healthcare costs, and Saul is the CEO and co-founder at HealthForce. He'll be joining us after his presentation for a Q&A, so get your questions in the Q&A box. Here's Saul now.
Hello everyone, thank you to Africa Health Week for having me here today. My name is Saul Koenig. I'm the CEO and co-founder of HealthForce, a company working in primary care and digital health, particularly telemedicine in South Africa. Today I'm going to be talking about escalating private healthcare costs and also talking about some of the innovative solutions to addressing them that we see happening, particularly through technology. The 2 things that we're covering today, as I mentioned, the escalating private healthcare costs, but also the opportunity for innovation. Starting with then the escalating private healthcare costs. There are 3 parties to the healthcare system that one needs to keep in mind when looking at healthcare. There is the demand side of the healthcare system created by patients who need healthcare. There is the supply side of healthcare created by the providers of healthcare. And then there's this weird third-party player in healthcare, the funders of healthcare, who pay on behalf of the patients to the providers for the patients to get access to care. I'm going to look at each of these 3 pieces and how they contribute towards the escalating private healthcare costs. So let's start with the funders, these third-party payers. In South Africa, using this as an example, there are around 57 million people. Of these, only 16%, or around 9 million, have access to medical scheme cover. The average price for medical scheme cover for a family for a month is around 3,700, 3,800 Rand. This is a little bit outdated, so it might be more expensive than this at the moment. If one compares this monthly medical scheme premium for a family to household income in South Africa, one sees that the vast majority of South Africans earn less than 6,250 Rand per month. That's 3/4 of the population, which makes the scheme cover completely unaffordable to them. In fact, the only category of household income here that could even think about paying for medical scheme cover is this category over here, those people earning as a household more than 12,500 Rand a month. But even here, if we take the lowest category of 12,500 to 25,000 Rand per month, and we take a look at the middle family earning income here of 18,750 Rand, you can see that this monthly medical scheme premium is 20% of household disposable income. That's a massive share of income to pay for something that you're not even sure you're going to need in any given month. So why is this so unaffordable? What we've seen over the last decade, and even more so since the advent of COVID, is that there's been a real decline in medical scheme membership in South Africa. And what I mean by that is that the proportion of population belonging to a medical scheme has declined. And in real terms, for the first time over the last year, absolute numbers of medical scheme members has declined. Now, medical scheme administrators who make money out of the medical scheme premiums collected on behalf of their non-profit pools of funds are needing to cover their costs. And what we've seen since 1990, since the end of apartheid in South Africa, when there was this massive burgeoning of private healthcare to cater for wealthy white South Africans who were scared their healthcare was going to get taken away by a new regime, we can see here that as people moved into private scheme coverage, there was an escalation both in administration costs as well as in non-healthcare costs. In other words, these costs over here are more than just administering the collection of premiums and the payment of claims from the scheme. They're about adding additional value adds to the medical scheme, such as pharmacy benefit management, that allows the administrator to generate additional income by creating value for medical scheme members. But this has created an escalation in costs and has made medical scheme coverage increasingly more expensive. However, there are another two large reasons why medical scheme premiums have had to go up so much over the last 2 decades in South Africa. The first reason is fee-for-service. What I mean by this is we live in a healthcare system where a healthcare worker only receives a fee when they deliver a service. In any system, when someone is paid only when they deliver work, they will try and deliver as much work as possible in order to make a living. And this is no different in healthcare. In order for a doctor to make a living, they need to deliver services to earn a fee. However, the incentive in the system is misaligned with keeping a patient healthy, where doctors and other healthcare workers over-deliver services in order to generate reasonably income for themselves while over-servicing the patient and often doing unnecessary things to help them. This increases the cost of access to healthcare. At the same time, funnily enough, it reduces health outcomes because healthcare is not a normal good. Healthcare is one of these strange markets. It's not really a market. One of these strange markets where at a system level, the more you pay, the less you get. The classic example of this is giving birth for a woman. In a system where a midwife looks after a mother giving birth, that mother has a 20% chance of cesarean section. However, where that soon-to-be mother goes to an obstetrician for care, that cesarean section rate goes up to 80%. A cesarean section is a serious surgery with complications, potential complications for mother and child. And at the same time, as a service delivered by an obstetrician, is much more expensive. Now, it's not the obstetrician's fault. This is the way the obstetrician generates a revenue. In addition, this is what the obstetrician is trained to do. The second reason why there's been a massive escalation in healthcare costs in the private sector is due to people moving to hospital plans. In South Africa, the regulations say that there are prescribed minimum benefits, PMBs, that every medical scheme needs to offer its members as an absolute minimum in terms of healthcare service. PMBs are largely delivered in the hospital setting. This means that as people become less wealthy in South Africa, as medical scheme coverage of more comprehensive plans becomes more and more unaffordable, so people are dropping down to the cheaper hospital plans. However, the flip side of this means that people are either waiting till quite late when they're very sick to get access to healthcare, because they know that when they're that sick and they go to hospital, at least their medical scheme will pay for them. Or alternatively, they're seeking care in hospitals and with specialists unnecessarily. Again, if you go to a specialist for access to care, it is much more expensive, and at the same time, it is often delivering much worse health outcomes. As people drop to hospital plans, people's benefits in the medical scheme become much poorer in terms of day-to-day benefits, which means they have less and less access to the lower cost and kind of preventative care that you get from primary care providers such as nurses and GPs. So the combination of fee-for-service and people dropping to hospital plans is pushing people to get more healthcare from much higher level specialists, much more expensive specialists than they need to get. Let's move now to the demand side of the healthcare equation, the demand for healthcare by patients. This is the distribution of population in South Africa by age group. If one considers that the young people and the old people of South Africa are generally outside of the working age, that only leaves 56% of the population to work. And of that 56%, the unemployment rate sits somewhere at 34%, depending on how you measure it. That leaves a very small percentage of the population who are earning money and who can afford to pay for healthcare on behalf of themselves and their families. It's no surprise then that the vast majority of people in South Africa need to get access to state services which are free because they simply cannot afford to pay for that healthcare out of their own pockets. And it's also then not surprising that a very small percentage of the population supporting their families with a higher level of income can actually afford medical scheme coverage, more costly private care services that are paid for by medical schemes. At the same time, the burden of disease in South Africa is quite different to the rest of the world. Patients in South Africa look nothing like Sweden, where, as you can see here, the blue lines are non-communicable diseases. If one takes a look at a market like Brazil, which is also considered to be one of the BRICS countries, one of the developing world up-and-coming countries, we can see even here, there are only 2 non-communicable diseases in their top 15 diseases in terms of disease burden. South Africa looks quite different. South Africa still has the majority of its diseases in its top disease burden being infectious diseases. There's something called the epidemiological transition, where a population moves from being mainly suffering from communicable diseases, infectious diseases, to non-communicable diseases or diseases of lifestyle. And that happens as society becomes wealthier across the board. In South Africa, we're very, very early in that transition, which means our disease burden is actually very high because we still have non-communicable diseases while our infectious diseases are even worse. So now we understand the patients. Let's take a look at the providers of healthcare, the supply side. This is the number of beds in South Africa since 1976. What you can see is that around 1990, there was a proliferation of hospitals building private beds, private hospitals with private beds. This happened after 1990 as an unregulated private healthcare sector burgeoned on the back of the fear of what a new regime would do to existing and high-quality public healthcare services. Where it is today is that 83% of the beds in South Africa are delivered, care in those beds is delivered by 3 listed companies in South Africa, each generating significant profits every year. This investment in hospitals has created the skewed system that also allows hospital plans to push patients into hospitals. And if one takes a look at medical scheme spend into those hospitals, you can see it occupies the vast majority of healthcare spend paid out by medical schemes. Let's take a look at specialists specifically. This is the number of acute hospital beds in South Africa. 3/4 of those beds are in public sector and about 1/4 is in private sector. Yet this 17 billion rand of specialists in private sector constitutes well over half of the country's specialists, serving just 1/4 of those beds. Private sector has a disproportionate number of specialists. Looking at overall healthcare spend in South Africa, one can see that the public sector spending in excess of 160 billion rand per annum and private sector spending in excess of 160 billion rand per annum are each 50% of the healthcare spend in the country. Yet this 50% of the healthcare spend is spent on just 16% of the population. And hopefully now you have a better understanding of why. It's a similar story in other African countries. There's single-digit health insurance coverage in every other African country. South Africa is actually the only country in sub-Saharan Africa that has double-digit insurance coverage at 16%. At the same time, Africa has the youngest and fastest growing population on the planet. Population in sub-Saharan Africa is expected to double, more than double, in the next 30 years. Africa has not gone through that epidemiological transition to diseases of lifestyle. In fact, by some measures, Africa has the highest disease burden of any region in the world, with 25% of the global disease burden. Mapped out like this map shows the size of the country in relation to the disease burden of that country. And you can see here that Africa is a very swollen continent, while continents like Europe and America and parts of Eurasia are almost non-existent on the map. Their disease burdens are so small in relation to India and Africa. At the same time, the distribution of physicians around the world is completely the opposite. This map here shows the number of physicians per country. Here you can see a very swollen America, a swollen Europe, and a swollen China. Yet Africa is almost non-existent. Because the reality is that with 25% of the global disease burden, we only have 2% of the world's physicians. So, hopefully you've got a better sense of why private healthcare costs are escalating in Africa, and in South Africa more specifically. What are the opportunities for innovation here? The only way to make quality healthcare affordable and accessible, this triad, this iron triangle of quality, affordability, and accessibility, is really what every healthcare system is trying to achieve. The only way to make that happen is to enable clinicians to work together in teams and to organize those teams around the patient. In other words, in a patient-centric manner. What does this mean? This means that, first of all, one needs to take a look at the level of complexity of the health issues of a population. And one finds that even when sick, most people in a given population are actually healthy. A young 25-year-old, even with COVID, is still a healthy person with lower risk of complications. There are very few people in any given population who have very complex conditions, who are very sick, who have so many comorbidities that even getting the flu can result in them needing much more complex level of care. This triangle is really, really important to recognize again that most people are healthy even when they're sick. And the objective of a healthcare system organized in teams is to allocate the appropriate team member to the level of complexity of the patient. So if one looks at resource intensity, a mostly healthy person, even when they're sick, may just need a single person like a nurse to help them, to look after them, or maybe a nurse and a GP. Whereas on the other end of the spectrum, the few people who are very sick will need a full team of healthcare workers, probably in a hospital, in an ICU, to look after them. By matching the team member to the need of the patient, one reduces the cost, improves the quality. Remember what I said earlier about primary care can often deliver better health outcomes than going straight to a specialist. And of course, it improves accessibility because the single resources, nurses and GPs, are more available and more accessible than hospital beds and super specialists. Healthcare ultimately needs to deliver care in one value chain, from primary care, which is nurses, GPs, pharmacists, psychologists, and even pathology, through to community care and out of hospital specialists, eventually into hospitals, through the specialists that I've got in this diagram here. And what needs to happen is that if there are clinicians working together in teams across the whole value chain, people need to get referred across this value chain based on the complexity of their need. In other words, a very complex person may end up over here, not a complex person, but a person with a complex condition may end up in a super specialist hospital. But once they've had that hospital care, they can often be maintained with a single resource, a nurse or maybe a GP, back at home or in their local community. Now, by way of an example, Health Force has developed a clinic product that sets up the nurses in pharmacy clinics to call a GP through remote telemedicine. And we're about to launch a new app that will allow patients to access that nurse and, if necessary, a GP and a psychologist on their phones at home. What this means is that by making nurses and GPs as a team available to the vast majority of the population who are healthy, we can capture them at the side of the pyramid and funnel them through to the more resource-intensive layers of the system as their need requires, as long as we're organizing those skills as a team around the need of the patient. Again, reducing the costs, increasing access, and improving quality. Health Force has been going for just over 3 years now. We're in over 450 clinic rooms across South Africa. We have over 500 nurse users, and we've done over 1 million patient consultations with those nurses. At the same time, we've delivered over 110,000 telemedicine consultations into those nurse-run clinics. And the average wait time without a booking to see our doctors on the telemedicine service is 1 minute, or at least it's been 1 minute for the last few months. After every consultation, patients rate our doctors, and the average rating of our doctors by patients is 4.95 out of 5. This is a classic example of how we're bringing low-cost GPs, and more importantly, setting up nurses as the lowest cost entry point into the healthcare system through the use of technology. Opportunity can be seen in terms of current trends as well. This opportunity of lowering cost of care and improving quality and accessibility by organizing teams of healthcare workers around the need of the patient. First of all, in the post-COVID world, we're seeing people drop off schemes, which, as you've seen, are more expensive, to looking for lower cost primary care insurance or moving into uninsured markets. This naturally sets up a situation where people can invest in delivering primary care services because more people want to get those primary care services. At the same time, fewer people then can afford hospital care, and they are seeking care in lower cost settings or through virtual care services. Essentially, what I'm talking about is something called value-based care, without having actually mentioned it. And value-based care is all about looking after patients and keeping them healthy with a team of healthcare workers, rather than treating them on a fee-for-service basis when they get sick. And our market in South Africa and across the continent is primed for value-based care. Why? Because as you've seen, our critical mass of disease burden is high. Got a critical mass there. That means that there's a huge opportunity to deliver care across the spectrum. At the same time, we've got a lot of compressible costs. We've got a lot of specialists and highly trained people helping people who should be dealt with in a lower cost primary care setting for better health outcomes. At the same time, there's an opportunity to translate a lot of the infrastructure we've got at the moment into high value sites of care, using technology to make more specialized skills available in things like pharmacies and nurse-led clinics, which previously was unavailable, setting those clinics up to be higher value points of care. And then, of course, there's this model moving to beyond the hospital, looking at setting up networks of diverse care delivery settings, such as pharmacies and nurse-run clinics and community health centers. Systems where you can capture a high market share and generate more profits and more growth in profits than if you sit in the existing high-cost hospital and private medical scheme market. And then finally, the highest value is delivered to the lowest economic quartiles from a business perspective. And that is simply because the focus up until now has been on delivering care to the wealthiest people in society, which means that as a business, if you want to generate more returns on your investment, the lowest economic quartiles are the people to try and serve. So from a business perspective, it makes sense to target creating teams to deliver high quality care in a preventative and early stage setting than it is to invest in specialized and complex care, which aligns with, as it turns out, better healthcare delivery to populations. As a last thing, I just want to mention how COVID has resulted in the rapid adoption of telehealth services. This was a US study. From a consumer perspective in the US, people moved from 11% using telehealth to 46% using telehealth after COVID, with 76%, three-quarters of the population, interested in using telehealth going forward. That's a massive leap from 11%. There's also been massive adoption from the provider side. In fact, 50 to 175 times the number of telehealth visits have been delivered post-COVID compared to pre-COVID. And 64% more providers in the US are comfortable using telehealth services. In fact, in the US, they estimate that the market will grow from 250 billion to 1.25 billion rand, out of hospital spend could potentially be virtualized, up from 3 billion rand. Sorry, dollars, I must say. So how do we eat this elephant? Because this is a massive thing to try and deliver a solution that looks like this. Or for vegetarians, how do we eat the artichoke? And the answer is always one bite at a time. The solution in healthcare is always to deliver something of functional value right from the outset. If one considers it and makes it, draws the comparison to building a car, what you don't want to do in healthcare is first build the wheel and then the chassis and then the mod cons on top of that. You don't just want to deliver something that's functional. You ultimately want to help the patient get from A to B, whether that means first building a bicycle and then a scooter, working your way up to an airplane. That's the approach you've got to take. When you deliver something across these levels that ultimately delivers something of functional value into the healthcare system, rather than delivering a small piece that's not functional and will have no impact. This is because there's no such thing as an MVP in healthcare. This was something coined by a big investor, tech investor in the US, who does a lot of investment into healthcare. And the reason there's no such thing as a minimum viable product in healthcare is because the incumbents in the market occupy and have captured the whole value chain in the delivery of healthcare. And if you want to offer something into that healthcare space, you have to offer something that's a significant portion of that value chain in order to be able to capture the market in that particular piece of the patient's process through receiving healthcare. And so ultimately, again, one wants to deliver something of value in order to capture something within that value chain and then build out from there. And so the solution to something like building a healthcare system which has teams of healthcare workers focused around the need of the patient, delivering care at an early stage at lower cost, is about building a solution that does just that, and then working with incumbents in the market to fulfill that aspect of the value chain that other people aren't fulfilling.
And here is Saul joining us now. Thank you for that presentation. An interesting concept. How hopeful are you, Saul, that they'll be able to grow this over time?
I feel hopeful. Otherwise I wouldn't get out of bed every morning and keep trying to do it. I think there's a healthcare is becoming increasingly more expensive. It's making less sense from a business side of things, and it's certainly making less sense from a consumer side of things. And there's also a huge impetus from the government to make universal healthcare accessible, not least of which is demonstrated through the National Health Insurance Program that they're exploring. So I feel quite confident that we're moving in the right direction.
I suppose there needs to be a degree of patience there. You know, you mentioned eating an elephant, and it can take a long time to eat an elephant. And even though you might do it one step at a time, you mentioned those early steps, many of which will be building the model around prevention, maybe education about being healthy in the first place. And how would you go about doing that?
First of all, I agree. This is maybe a multi-generational project in our hands to revolutionize a healthcare system and set it up for the future, changing the way incumbents work for the benefit of that. Certainly, you cannot deal with healthcare unless you consider the socioeconomic elements of an individual and a population in delivering that healthcare. I think that we are in the modern age where collection of data is easier and easier, and where turning that data into meaningful analytics is also increasingly easier. So I think collecting that data and making it readily usable and available to clinicians and to planners of healthcare is probably an important step. Look, I think because every consumer of healthcare on the planet will shortly have an intelligent device in their hands, it becomes increasingly easy to monitor them, to push content to them, to use behavioral economics to incentivize them to look after their health. And certainly all the devices they're going to be wearing will feed that data through, like as simple as a watch, for example, like Apple Watch.
Yeah, you mentioned there that there's been an escalation in the uptake of this technology since COVID-19. It's often the way, isn't it? You know, it takes an international, global pandemic tragedy or a war that moves technology on, and not just that, the uptake of that technology. And we're seeing quite positive results, aren't we? I think we were, perhaps the older generation particularly, a little bit cynical about using that device that's in our hand for these purposes. I mean, it's way beyond a telephone these days, isn't it? It's if it can, monitor your health and give you access to those services, then we really need to be investing in that technology and the education program that will come with it to make sure people use it.
Absolutely. Absolutely. It is like the reality with healthcare, irrespective of the fact that this pandemic has accelerated the use of virtual care and telemedicine. Healthcare has always been an incredibly slow industry to adapt to new technologies. And then it makes sense. You're dealing with people's lives. You're going to be more conservative in changing to new things that you may not trust or may not be proven, or there may be complications or unintended consequences that aren't fully understood. And so, I mean, I think I read the other day that when the stethoscope was invented, to the time it was commonly used by doctors was almost a century. And that's how slow adoption can sometimes be. We're in a different world where things are adopted a lot quicker. And so, yes, in this situation, it took a pandemic where we didn't want to go into the doctor's rooms to contract a serious illness there that from other patients that had been there, where doctors, for that matter, didn't want their patients coming into the rooms to contract the same illness, to accelerate this adoption. And I think the acceleration of the adoption of this sort of telehealth and virtual care has been for the positive. It makes an additional layer of care available that wasn't there before. There certainly are situations where it's still better to see the patient in person. But this definitely widens the funnel through which people can be funneled into the rest of the healthcare system without having to go seek out physically a nurse or a doctor or some other specialist.
Yeah, I was thinking there of my own parents who, during the pandemic, did suffer some illnesses, weren't able to access the doctor. So we had a presentation prior to yours about local community nursing, people visiting, and making sure that care is delivered, particularly to the elder population, because not just the elderly population don't always understand or take up the technology or even have the smart device in the first places, but often they trust people, don't they? They trust the uniform, they trust the doctor, they feel safe in a hospital or in a doctor's surgery, even though perhaps their youngers are saying to them, yeah, you really don't need to go there and queue up. This is available in your palm of your hand, and they just don't get it, do they?
Well, healthcare's got two components to it. Rationally, you want to feel better. You want to get the appropriate medications, the appropriate procedures, the appropriate advice. But at that same time, you mustn't underestimate the importance of the emotional aspect of healthcare, which needn't have anything to do with actually the treatment to get you better. It can be just that sense of feeling cared for that can make a massive difference. So you can imagine a mother bringing her young child in. The young child is very sick. Yes, the doctor may give the medication and may do the appropriate wound care or provide the appropriate treatment. But if that doctor doesn't allay the mother's fears, despite the fact the child's got what they needed, the mother's not going to feel better. And as a result, probably the child won't feel better either. So one has to consider the fact, when we talk about elderly people, it's not just elderly people, it's also young people who want to feel cared for. It's just that younger people are more likely to feel cared for over a piece of technology where human beings on the other side than people who are less used to using that technology.
Yeah, and I think you're absolutely right, is that sometimes that reassurance, you just want to know when a doctor or a nurse or a medical practitioner says, in my opinion, I've seen this before, it's quite natural and you're going to be okay. I mean, that in itself is worth all the medication in the world, isn't it? So we need to embrace that. Thinking now of the cost and the rising costs, I mean, people chase the money, don't they? That's the problem, is they chase the quick money, the money that they can get straight away for the more expensive procedures, et cetera, which we're trying to stop. And that's what I'm getting from your presentation. And that, but they don't necessarily see the benefits of reducing the illness in the first place, the benefits to the economy, to communities, to society in general. Less poor health means more wealth, doesn't it, in that respect?
Yeah, absolutely. I mean, so I actually slightly disagree with you here. I'm sorry if this point didn't come across well enough in my presentation. I don't really think it's the clinicians' faults. And I don't think that is the health insurers' faults. I think that the system has been set up to create certain incentives for them to behave in a certain way. If an unregulated, listed insurance company is pursuing profits, and it needs to pursue profits because that's what its shareholders want, and the system is not regulated, then they will do what they need to do to make those profits. And that's completely within their rights. That's the way the system has been set up. At the same time, a provider who needs to make a living through delivering services, and they need to deliver more services to be able to make a living or to make a better living, they will continue to do so. And one thing I've realized, by the way, with clinicians is that despite the fact they work in the health system, they don't actually understand the health system within which they work a lot of the time. And so I think what needs to happen is not just asking these parties to the healthcare system to change. I think what needs to happen is there needs to be systemic change, regulated change, and change that, if guided in the right way, will actually make things more profitable and more pleasant for funders and for providers, for the demand side for healthcare and for the suppliers of healthcare and for the funders of healthcare. Everyone can benefit. But in order to coordinate that change, there needs to be a coordination between different parties, a willingness to do so, and there needs to be a degree of incentive to make that change.
Yeah, thanks for explaining that. That does make that perfectly clear. And those incentives, how would they look? What would you see as a good incentive?
At the most basic level, what you want to do is you want to pay healthcare workers to keep people healthy, not to treat them when they're sick. If you treat them when they're sick, then you don't have an incentive to make them get better at a very crude level. Not that I'm saying doctors don't want their patients to get better. Whereas if you're paid to keep someone healthy, irrespective of whether they're sick or not, you're going to try and make sure they never come back to your doctor practice, that they never come back to your hospital, that they never come back to your nurse again. And so you can do everything in your power to treat the root cause, or to refer that patient to the appropriate level of the healthcare system where they can get the appropriate level of care, because your objective is to make sure that you can have as many people under your coverage as possible, because you're going to receive a fixed fee per person under that coverage. And if every single person is sick there, you can only see this number of people. But if very few of those people are sick, then you can look after a much bigger pool. And so there it makes sense from an incentive perspective to keep people healthy.
Well, and on that note, Saul, I think you're absolutely right. Who would disagree with that methodology? Let's hope that this elephant eating contest starts straight away and progress is made. I'm using your analogy there, of course, but it's good that we've got people like you on board, spreading the message and bringing that to everybody's attention, particularly during Africa Health Week. You've actually had the closing presentation, and I think that is the perfect way to close it. This idea that, let's prevent, let's keep people healthy in the first place. Let's bring costs down. Let's make things accessible. Let's scale. Let's use the available technology. All of those messages came across loud and clear in your presentation. So I want to thank you and enjoy the rest of your day wherever you are, Saul.
Thanks so much for your time. Glad I closed.
Thank you. That's Saul Cornick there. Thank you so much to Saul and all of our presenters, not just on today, but throughout these 3 days that we've enjoyed at Africa Health Week. The presentations are all available to catch up and view again on the YouTube channel. Future Health YouTube channel is where you'll find them all. We've had some incredible sharing of ideas and knowledge, education, plans, thoughts, and that conversation can carry on. You don't have to leave us now just because the presentations have come to an end. The platform stays open for another 24 hours. You can network and chat. And of course, if you want to take that chat offline, you can take it with the contact details that some of our presenters have shared. Or you can stay online using the hashtag Africa Health Week or Future Health, and just use the hashtag on social media and connect there as well. So there we are. We've had 3 brilliant days. It feels, for me anyway, a very positive 3 days of presentations and discussion and debate. I'm full of hope. I'm sure you are too. It doesn't end there. Of course, if you've attended any of these days, you can pick up your CPD points. They will be credited to you automatically. I mentioned that we are not just in Africa, that we are global. We are going around the globe over the coming months. We've already been in the UK and in the Arabic world. We are going to be in the USA from the 1st to the 3rd of September. So do register for our Health Week series there. Save the date, the 1st to the 3rd of September for USA Health Week, and we'll be going on beyond there to other parts of the world as well. All it remains for me to do is to thank the organisers and Future Health Innovations, all of the partners, sponsors and people who've been involved, of course, our presenters and the staff that helped put the technology together to bring this to wherever you are. Wow, normally we'd all be in the same room. Let's hope we can be very soon, but the fact that we can bring it to wherever you are in a safe way is incredible. And especially a thank you to you for joining us. Thank you. Thanks for your time. Keep up the great work. And we'll see you all in the USA on the 1st to the 3rd of September. I've been Dave Sharp, your host. It's been an absolute pleasure. For now, take care. Stay safe.